Dr. Chirag this side, and a very good afternoon to all the delegates. On the outset, first of all, I would like to thank the Kolkata Arthroscopy Association, especially my good friends, Dr. Rajiv Raman, Dr. Biplab Da, Dr. Swarnendu sir, and Sunit sir, so on and so forth, for giving us this platform and putting up such a beautiful show. Let me first run through this.
Just give us a little bit of preface of the case.
Yeah. So this is a young guy who's had a recent history of trauma. He is moderately built. His BMI is about 28. And he seemed to be a non-contact sports person. His sedentary lifestyle, and on examination, his Latchman was grade 2. His pivot shift test was just a glide, and joint line tenderness was more prominent on the lateral side, and he did complain of occasional locking after his injury. Now, when I went inside, I did see the MRI. I had a suspicion that it is a kind of a Sherman type 1 of a tear, and as I see here, it's more of a femoral side peel-off tear of the ACL.
Correct.
Now, I have just debrided a little bit, and what I would do usually in such cases is I will like to recess the Sharpie's fibers and then define the ACL before I go ahead and do anything about it. I have cleared out the ligamentum mucorum and then reached out to the ACL. ACL is probably a peel off. It's like a type 1, and typically the PL bundle is just peeled off here.
Yes.
So it's very disheartening if I would remove off the entire ACL and do a ACL reconstruction.
Yeah.
But of course, this gentleman did say about the lateral side knee pain, typically the posterolateral corner, he said of pain. So we either suspected a PLC injury, which was negative on clinical examination. Let me just see if I can have the drive-through sign, which is positive. We did assess it before I started the surgery, and the drive-through sign is negative. That arises a suspicion that there's something more than just a PLC. And even though the MRI didn't clearly tell me about the tear, here what I see is I see that this
small
is a
root.
focal type 1 of a tear of the root of the lateral meniscus. Now let me just, since it's a fresh injury, there's a little bit of bleeding, and I would like to define my tears before I would repair that. And here I see it's not a classical root avulsion, but we all know that anything within 1 centimeter of the insertion is still considered as a root tear, and this is classical of that oblique kind of a tear here.
Yes.
So how would I repair this? I would repair this with the all-inside technique. Here, 2 challenges here. Give me a needle, please. It would be technically a little difficult to get my all-inside device through my medial portal. So what I would do, I would switch my portals. Vicinge rod, please. So I would switch my portal, and the better way of doing it is by using the Vicinge rod. I have placed my Vicinge rod here so that my camera insertion becomes a little easy. I would switch my portal. I would take my camera through the anteromedial portal now. Visualize, use this as a viewing portal.
So you're going to work from the lateral portal, see from the medial.
Yes, I would work through the lateral portal now. Yeah, can I have the shaver? Don't keep a thing here. Switch on the water, please. I have a good team to assist me here. I have 2 of my fellows, Dr. Vincent and Dr. Mohit, and I have the nursing staff, which is well trained by Dr. Raman. There should be no doubt about it. And I see here, I am trying to work through my lateral portal, but again, there is some amount of, probably a little bit of constraint here, probably a space constraint for me to work here. It's hardly opening up to about 4 millimeters. Now what I would do at this point, I would ask my assistant to lift the leg up. Yeah, the foot gets lifted up, and that makes my vision better. Let me see, let me get my trajectory right. Give me a long spinal needle, please. Give me a long spinal needle which is rigid, not this. Let me see if I can get my trajectory right. Oh, of course. Here it is. Yeah. Now I would introduce, give me a knife. Yeah, I will introduce my cannula, my meniscus repair cannula, and that is very important to ward off any form of a soft tissue and to make my passage of my all-inside instrument a little better. Here I am. I would place it here. And then I would use this Air 2 device. I'm very fond of this device. If you see this, can I have the camera, please? Camera?
Can we
Here?
have the outside camera?
Yeah, outside picture. If I could just give you a brief of this Air instrument, this is I would say it's a fourth generation of our, third generation plus of our meniscus repair devices. It has got a graduation up to 24 millimeters. So I have a space up to 2.4 centimeters I can go in. It is audio plus video. So my deploying of my peak would be with the audible click and of course the visual confirmation through these slots which are available here. It's a very malleable needle. It is thin, 1.3 mm. So the dent which I make in my meniscus would be little less. And it's a peak material which I'm going to deploy. The failure in my hands for the last few months where I've been using this has been literally nil. I'm very happy with this device and I think it wouldn't fail in my hand today as well. So the first bite where I will take, I have graduated, I have placed it to about 18 millimeters. Since I'm working towards the posterolateral corner, I would not go beyond 2 centimeters. So I have, first what I do is I take this, can I have this? I take this clip back and then I click it in. So once I've done that, I would then retrieve my first placement and then I would want to, this is a difficult part of it, to get a good tissue bite is a little bit of a challenge sometimes, and you will see that there's also a capsulomeniscal kind of a tear. So I would go there, take a deep bite, and again a click back and a click inside. Once I've done that, this is a horizontal mattress suture which I've taken. I would just tension gradually, and this is a double cinching knot which is seen here, beautifully closing that.
Yeah, that's very nicely done.
Yeah, I would then take my knot pusher cum cutter, gradually titrate the tension what I'm giving. These tissues are sometimes flimsy. You do not want to cut through that. Until unless you have a good approximation, I'm happy with that. Sometimes one can take a crisscross suture, which is not required here, especially with this kind of a tear which is approximating well. I don't think I need to do anything beyond that because I'm going to do something with the ACL which is going to generate bleeding as well. Here I am. It's repaired well.
That looks very nice.
Your root is seated well. And I'm not going to do anything behind this. I don't think anything is required. As I cycle it later, you will see that this is going to sit flat. Now it's very important. Can I have the external view, please? Look at my assistant what he's doing. He's lifting up the foot, as simple as that. Sometimes we give this undue pressure which is not required. See the opening what I get here inside. Intraarticular opening is very well. That is more than about 4 or 5 or 6 millimeters. And any form of a posterolateral work can be done with that. Now we switch our attention from Deepika to Ranveer. I go to the man here, and that is ACL. The ACL seems to be a Sherman type 1 of tear, as I said. So my intention here and my effort here today would be to probably save this ACL and probably do a primary ACL repair.
How are you planning to do that?
Yeah. So I'm going to use knee scorpion and I'm going to suture it and use probably a kind of a push lock or swivel lock kind of an anchor, which is called as the Omega anchor by Stryker. First thing what I need to do is I need to probably, if I'm going to accommodate an augmentation, I need to make the notch a little wider. What I'll do is I'll take a gentle scoop. Give me a scoop, please. I would take a scoop and try to scoop out these kind of Sharpie's fibers from the notch. This the lateral notch. I'm just scooping it out for two reasons. One is I will get more space. Second is it will kind of create this bleeding surface. I can do a micro puncturing later, but I would first scoop it out to see all this punctate bleeding as you see here, and that punctate bleeding will facilitate my healing of my ACL repair. Once I have done with that, if I'm doing an additional augmentation, I will always do a notchplasty. Here, let me see. I will take a call on the augmentation once I have repaired it. As you see here, it's more of a, can I have a probe please? As I see here, it's more of a PL bundle, which is avulsed, and I would definitely not remove this. There's good amount of bleeding. It's more of a kind of a peel off. Now, can I have the needle, long needle? I would always use an additional portal to do this kind of a repair work. I would use a central Gilkis portal, which will facilitate my easy passage of my instruments. As we'll see, I have done that. I've taken my central portal here. And next thing what I do, cannula please.
Is it you routinely take a central portal?
Sometimes for my ACLs, but I'm doing an repair here, so I will for various reasons. Can I have the 7 mm? 7 mm. Okay, here we are. I have taken this. This will make my life a little easier. Can I have the scorpion, knee scorpion? My knee scorpion is loaded with a fiber tape. Now, why I have taken that portal, we will get to know now. Can I have the eye stong, please? I'll introduce my knee scorpion through this. Retrieve the cannula a little bit. Dr. Vincent? Yeah. So that is good. Hold this, please. And I will ask one of my assistant to pass the suture retriever and hold the tissues of the ACL in this manner. What happens usually, once we take the bite, sometimes the tissues are so friable that they can, hold that please, yeah. Now what I do, I will take a bite. I have loaded the thread in the center. I will take a bite through the good chunk of the PL bundle. Let me see if I can go. Can I have a little bit of pressure, please? Kindly raise the saline. If you keep it at that level, I won't get any kind of a, yeah. I need to get a good tissue bite because it's very important that I do not cut through. So I am trying to get an isolated bite through the PL bundle. Here I am. That is not good enough. I am not happy with that. Hold this, please. Hold the camera. Yeah. Here I am. I am not really happy with that bite I would get there. So what I would do, I will change my portal through which I will take the bite. I will now put my retriever through this portal. Ask my assistant to hold it well. Hold this, please. I would then introduce my scorpion through that and take a good bite from here. I am probably happier taking a bite from this portal, but again, yeah, that would be a little better. Once I've taken that bite, now it's very important that when I pull this, I do not unduly stretch out my ACL fibers. So it's very important. Hold this. Hold that firmly. Leave. Michael, hold this back. Yeah, hold this. Push it back. Push it back. Yeah. So give a counter push back so that the fibers do not get cut through. Excellent. Hold this, please. So I have load the knee scorpion with a fiber wire. I have taken a self-cinching knot here, and if I see, it's very delicate, this step, so that I get one bite there. Since I'm dealing with only a PL bundle, the bite may look a little more flimsy than what it would look. Next, what I would do, I will switch my viewing portal to the anteromedial portal. Kindly load it. Guys, you need to be a little quick when I talk and when you act. I will load this with the fiber tape again. I'm not getting any response from the hall. Is everybody slept off or?
Everybody is very interested.
What's happening?
Yes.
Okay, I have switched my working portal and my viewing portal, the anteromedial portal, and the working portal, the anterolateral portal. Once again, I mimic the same steps. I then take a bite here, and now I would introduce my eye stone, suture retriever, hold the stump there, and then retrieve. This is very important. This step I learned after a few cases where I spoiled my fibers unduly, trying to give that tension. Put this inside.
So you have cut through before.
Yeah. Sometimes if you do not do that, hold that tissues, there will be a definitive cut through of the fibers of the ACL, and that's when we land up in trouble. If you see here, I've got good 2 bites. Now what I would do, I would retrieve both of the suture materials through a single portal. Yeah, once I've done that, I have retrieved one. Now I will have to retrieve the second one. So I will go to my conventional portal. I'll go to my anterolateral portal. That will make my job a little easier. Yeah, I've retrieved all the 4 suture limbs through a single portal.
That's your central portal.
That will give me a better things to handle my sutures. Okay, now next what I'll do, I'll take the radiofrequency ablation. I need to go past the residence ridge so that I don't stay very anterior when I'm repairing my ACL. So I'll clear out the Sharpie's fibers. This is the insertion of the PL bundle. We all know at 90 degrees of knee flexion, the PL bundle is a little lower and anterior to the AM bundle. So I'm going to place my anchor here. So this will be the spot where I would repair my ACL. Once I've done this, I would now mark out where I'm going to place my omega or a knotless anchor. Now what I would do, I would place my cannula in the anteromedial portal because that's going to be the a spot from where I'm going to introduce. Can I have the inserter?
So your sutures were in the central portal, right?
Yeah, I will retrieve it back.
Yeah.
Hold this. That I put it there so that my working portal doesn't hamper my retriever, please. I pull them through my anteromedial portal now. All the 4 limbs are in the anteromedial portal. Gently so that I don't have any cut through. Hold this, please. Yeah. So I will now place my limb in 90 degrees of reflection. And give me a probe. Let me see where I have placed my spot where I would repair my ACL. Okay, this is where I'm going to repair my ACL. This is the residence ridge, and I'm going to be just behind that.
Yeah, that
now let me get the omega anchor. Hold this. Get the anchor.
So you're going to pass it through the eyelet first.
Yeah. So this is a next generation of knotless anchors. If you see this, it has got 2 components. One is only the eyelet here, and that is what is going to engage my threads and through which I'm going to pass. Can I have a knife? Knife. Here you are. I'm going to pass all the 4 limbs of the sutures. That's a fiber tape through the limbs, all the 4 limbs through the eyelet, and I'm not going to unduly tension it in this at this point. I'm going to it's a self tapping kind of an anchor. So this was where my spot was. What I'm going to do at this point, I'm just going to tap it. Yeah, Vincent, tap it.
So
Tap it.
So this anchor saves you from when you use the swivel lock, you have to make a
Yes,
hole before.
Yeah. Yeah, so I need to go till that mark, laser mark there, little n, little n. Yeah, yeah, fine, fine. I'm done. Now I'll have to reverse tap this. Give me a mallet. Hold this. I just need to gently reverse tap. And here it is. It is well engaged. Now I can tension this. Hold this. I can titrate my tension here. I can just pull one of the limbs, and you can see here it's gently getting tensioned.
Can we go into the arthroscopic image, please?
Yeah, you can. Arthroscopic view.
So we've got.
If I want to tension it further, I just need to pull these limbs. It will get tensioned by itself, which I don't think is required here, not cutter. And now I have the second component of this omega anchor. If you see this, there's a second component which is going to lock this threads into the eyelet. So I'm going to introduce it. The only thing is that it has to be placed properly in the right direction, in the right place. So here I am going to hold the tension of these threads in this slot which is there here. And what I'm going to do is I'm going to engage or lock these sutures into this second part of my omega anchor. Look at that, the ACL falling tight, and I get a good hold, and then I release this and pull this anchor out. Can I have the cutter? This cutter looks toxic, yeah? Give me something else. I have my, I have, this cutter may not be really the cutter which I would have wanted to use. Yeah, once I've done that, can I have a condyle pick? Can I have the condyle pick? Yes. And can I have 3.5 mm shaver, please? 3.5 mm. 3.5 mm. Yeah. Can I have the condyle pick? I would generate some amount of biology. Of course, there's a pilot hole which is more than sufficient. I have scooped out. That's also more than sufficient. Now, what I'm going to do is I'm going to create a couple of small puncture holes here, so that there's an additional biology for healing. Now, if I see this is my ACL. That is the posterior condyle, and let me see it from the anteromedial portal. This is my ACL, which is repaired. Let me see the tension of this ACL.
Yes, show us the tension.
Give me a probe, please. Okay. Now, this is my primary ACL repair. A good anatomy, a good tension. I don't think I even need to, it's only a PL bundle which I've repaired. So his AM bundle is intact. I've not done anything with that. Of course, the PL bundle primary repair, and I don't think I need to do anything more than this for him. I'm not going to augment this with a ACL graft. In case if I wanted to augment, I would definitely go over the top. I would go over the top. I still have place here. I would put my I would augment it to the as like an AM bundle. I would put my tunnel here and go over the top here in somewhere near the AM bundle. Use a single fold or a two-fold Semity graft with about 6 mm and augment this like an primary ACL repair and augmentation. I think that should be enough. I think I'm in time.
I think that is a very well done ACL repair.
With an primary ACL repair as well. I would once again thank the organizers for inviting me here, and I would love to see you all again. Thank you.
Thank you. Thank you.